Chapter 7, Ventilation, Perfusion, and Shock, Understanding Pathophysiology. So this chapter is really the launching point for everything from here on out. The concepts of perfusion or shock are essential to being able to properly assess our patients and come up with a reasonable treatment plan. It identifies the fundamental existence of emergency providers in that we need to assess and identify potential life threats, and we need to provide life-saving interventions. And that all revolves around our understanding of perfusion and shock and our ability to identify where there may be something that is affecting that. So getting into the chapter here, let's first talk about pathophysiology. That's what we're going to be doing throughout the rest of this class, is we're going to be studying different disease processes, whether they be chronic or acute, that impact the overall perfusion status. So for instance, as we start talking about respiratory issues, respiratory ailments such as COPD, for instance, or asthma, those things will impact the ability for the body to properly perfuse itself. As we get into diabetes, diabetes and the inability to utilize sugar efficiently, that impacts perfusion. So everything that we talk about throughout the rest of the semester is going to revolve around our ability to assess and identify anything that interferes with the perfusion process and the ability to develop a reasonable treatment plan. So the fundamental component of our existence is the cell, right? The most basic unit of life. Now, I'll be the first to tell you that I don't know all the stuff that you need to know about cells and biology and everything else. I sat through my biology classes, and I remember little bits and pieces. But having a general understanding will at least be important as we start to talk about cell permeability and some of the different functions of the cell that correlate to perfusion. So a few things to understand. The concept of adenosine triphosphate, or ATP, is going to be important. That is the energy production that we're trying to accomplish. In order to create this energy or create this ATP, we need to utilize glucose, oxygen, and water. Those are the three main components that are required in order for us to create ATP. So we'll think about that a lot as we identify things that are going on with our patient. What's their hydration status? Do they have enough oxygen in their body? And are they able to efficiently utilize glucose for the metabolic process? So nice diagram of the cell. There's a video coming up in a few minutes that I'll show you guys, and that'll give you a much more in-depth overview of the cell and its functions. So we know that cells need water. They need to be balanced. If we are dehydrated, or it is possible to actually flood ourselves out, in those cases, the cell doesn't operate efficiently. There's a relatively narrow level of balance that we need to achieve, and that's done through a handful of things. When we think about hydration, it's not just how much water are we drinking, right? If I drink coffee all day and I'm dehydrated, does that mean that my cells don't work? Not necessarily. In a normal, healthy body, we're able to offset relative levels of dehydration. But if I go for prolonged periods of time without drinking enough water, by taking in too much sugar, too much caffeine, that could impact it. But more often than not, when we're looking at true dehydration issues, it's a result of maybe heat emergencies, some type of bleeding, or other issues along those lines. So glucose in the cell. We know glucose is the building block for energy. Without glucose, we create no energy. And that's one of the biggest challenges that we have with our diabetic patients. If they're not able to utilize the glucose efficiently, if they're not able to take that up into the cells, they're not able to generate energy. In those situations, we start to see altered mental status, and if it's left untreated, potentially death. So oxygen, we have two different types of metabolism that occur. Aerobic metabolism uses oxygen. This is normal. This is what we want to happen on a regular basis. This is what we're trying to achieve. Anaerobic metabolism does not use oxygen. And there's several reasons that could occur. Consider my arm. If I were to put a tourniquet on my arm, then I'm occluding all blood flow to all the tissue beyond the point of that tourniquet. So in that circumstance, I'm not allowing any oxygen into the bloodstream of my arm. I've cut off all the blood supply to the arm as a whole. So now all of the tissues inside of my arm still have to function, they're still utilizing energy. The muscles within the arm are still utilizing energy. And as they do that, there's no oxygen that is present. So it begins to create energy without the use of oxygen. Now, it's possible. It's not very efficient. It doesn't work very well, but it can happen. And when it does, when we're able to generate energy without oxygen, again, we refer to that as anaerobic metabolism. Now, because this process is so inefficient, and because we're not utilizing oxygen like we need to, the byproducts of anaerobic metabolism is a lot of acid. It actually creates a substantial amount of waste as a result. And the bigger problem is if I'm not able to get oxygen to the cells, I'm also not able to get rid of all the waste products. So in this case, not only do I have an inefficient way of creating energy within my arm, but I'm also unable to get rid of all the waste products. I start to see a pretty massive acid buildup. What we see is that's actually a sign of, if any of you have ever gone to the gym before and you've worked out, gentlemen, you've probably sat down on the bench press and tried to impress a couple ladies in the room, and the next day or 2 days later, your arms feel really sore. You think to yourself, wow, that was a really good workout. And in fact, it was. You worked out those muscles really well. What happened, though, is during the time that you were working out, those muscles were requiring far more oxygen supply than the blood was actually delivering to them. As those muscles were working, as they were trying to grow, they needed tons and tons of oxygen. And although the rest of your body functions were operating normal, there just wasn't enough oxygen getting to those tissues during that time. So what happened is the muscles still utilized the process of metabolism to create energy in order for them to work, but they did it through an anaerobic process, meaning that there either wasn't any oxygen or in this case probably wasn't enough oxygen getting there. The result of that were these acids. It actually creates what's called pyuric acid, which ends up turning into lactic acid. Those lactic acids sit inside of the tissues, inside the muscle, and that's what actually makes you feel sore over the next couple of days. As you stop working out and you return to normal function, oxygen supply to those muscles becomes sufficient again, and as the process slowly kicks back into an aerobic phase, you're delivering more oxygen, and you'll slowly start to pull all of that excess acid out. Now, so long as I'm limiting this to simply biceps, triceps, or something like that, it's not the end of the world. But when this becomes a systemic problem, when I'm not able to deliver enough oxygen to all of the tissues of my body, but especially some of the vital organs, the brain, the heart, the lungs, the kidneys, the liver, stuff like that, when anaerobic metabolism occurs within those things, that's a significant life-threatening event. And essentially, that's what hypoperfusion or shock is going to result in. And we'll get into those concepts in depth in a few minutes here. So you'll see here that the cell allows glucose to be brought in through the cell wall. Coincidentally, we need insulin. Insulin actually kind of unlocks a door in the cell wall that allows that glucose to get in. As that glucose enters in, along with oxygen both, they combine, and so long as the cell is properly hydrated, then all three of those elements in unison will create that ATP, or adenosine triphosphate. And again, that's our basic metabolic function there. That's what we're trying to accomplish, and that's what keeps us alive all day, every day. In the instance here, you'll see that we still got glucose in. Hydration level is still there, but we didn't have any oxygen. We're doing this without oxygen now, so this is anaerobic metabolism. The byproduct here is, yes, we do get some ATP, not very much. It's very inefficient, and we have that pyuric acid that builds up, that then turns into the lactic acids. Okay, so this is bad. Again, if it's focused on just a couple muscles because we're in the gym, not the end of the world. If it's systemic or it involves any of our major organs, that's a big deal. That's a life threat. Now, as we begin to talk about disease processes, we're going to talk about things like poisons and allergens and stuff like that throughout the semester. Essentially, what the body does is the body takes action in order to protect the cells, and as the body responds, it does everything it can to prevent any of these things, any of these toxins, poisons, allergens, whatever from getting into the cells themselves. If these foreign bodies get into the cells, they can do some pretty substantial damage. One of the things that can happen is it creates a permeability in the cell wall. As that permeability exists, it prevents water from either being brought in or retained sufficiently, and it also has the potential to do physical damage to the cells. So these are all things that, again, as we identify the potential threats that an allergen or a toxin present, we need to figure out how is the body handling this? How is the body responding, trying to protect itself? And as in the case of an allergic reaction is actually the body trying to defend itself from this allergen, from this thing that it perceives as a threat. So as we administer Benadryl, as we administer Epi, as we take all of these steps to combat against the allergic reaction, what we're actually doing is fighting against the body's own defense mechanisms. But with an allergic reaction, the body's defense mechanism goes so overboard, it's so exaggerated that it becomes an anaphylactic issue and it becomes a life threat. So yeah, the body actually kills itself in an attempt at trying to protect itself. So here's the video that's going to explain a little bit more about the cell structure. I'll let you guys listen to this. Enjoy.
A human cell consists of 3 parts: the cell membrane, the nucleus, and between the two, the cytoplasm. Every cell in the body is enclosed by a cell membrane. It maintains the integrity of a cell and controls passage of materials into and out of the cell. The nucleus is the control center of the cell. The nucleolus is a dense region of ribonucleic acid, RNA, in the nucleus, and is the site of ribosome formation. The nucleus determines how the cell will function. The cytoplasm is the gel-like fluid inside the cell. All of the functions for cell expansion, growth, and replication are carried out in the cytoplasm of a cell. Within the cytoplasm lie intricate arrangements of fine fibers and distinct structures called organelles. Each type of organelle has a specific role in the function of the cell. Examples of cytoplasmic organelles are the mitochondrion. Round, long cellular organelles produce energy for the cell through cellular respiration. Ribosomes, RNA-rich cytoplasmic granules that are sites of protein synthesis. Endoplasmic reticulum is a system of vesicular and lamellar cytoplasmic membranes that functions in the transport of materials and the Golgi apparatus. A cytoplasmic organelle that consists of a stack of membranous sacuelles and vesicles that is active in the modification and transport of proteins.
Okay, so all that's really important, and you need to understand all of that in depth. You'll be tested on all components of the cell function, and everything else. Nah, I'm just kidding. You're not really going to be tested on any of that stuff. Actually, I had you watch that video just in case you thought that my presentation was boring, as a reminder that it could be far worse, okay? In all honesty, have a general understanding of the cell, its basic structures and functions, but no, you're not going to need to get super in depth like that video offered, okay? Getting into the cardiopulmonary system here. So again, as a reminder, we're looking at this word cardiopulmonary, 2 different things there. It's referring to a combination system that involves both the heart and the lungs. So the respiratory and cardiovascular systems, they work together, and that is the absolute truth. They must work together in unison at all times. If they fail to work together, then the result is going to be a hypoperfusion or shock, and as long as that is the case, we are at risk for long-term permanent injury or potentially death. So together they work to bring the oxygen into the body, to get rid of the waste products. They want to distribute the oxygen itself to the cells. They want to get rid of all the waste product from the cells. So again, together they are a distribution and removal system that gets the oxygen to the cells and gets all the carbon dioxide and other waste products out of the cells. This is the most basic fundamental explanation of what perfusion is. Again, delivery of oxygen to the cells, removal of waste products. That's what we're trying to accomplish. So the basic structures of the airway that play into the process of perfusion are shown here, right? We bring air in, it enters in through the nose and through the mouth, it goes down through the posterior pharynx, enters in through the trachea, down through the carina. Carina is actually the junction here where the right and left mainstem bronchus split apart. And then from there, it distributes into these small little tree-like structures that are called bronchioles. At the end of the bronchioles, then, are these alveoli, and they look like little grape clusters. And these alveoli are wrapped in spider webs of capillaries. And remember that capillaries are the only vessel in the body that allows for the diffusion of gases to occur. So here, as the spider web of capillaries wraps around the alveoli, it allows the oxygen that was just inhaled to be sucked into the capillaries, and at the same time, the carbon dioxide gets pushed back out into the alveoli, and then as we exhale, we get rid of all that carbon dioxide waste. The other thing I want to point out here is the smooth muscle that wraps around the bronchioles. When we get into respiratory issues and we talk about things like asthma or even allergic reactions, the smooth muscle in the bronchioles, it actually constricts down, and it acts like a boa constrictor or a python. It constricts around those bronchioles. It causes those passages to become super small, and it really restricts airflow through there and the overall tidal volume that we can exchange. And we'll get into that more in a minute. So looking at this, this is kind of a hodgepodge that I took two different images and blended it together. So this is not to scale. But again, air comes down through the trachea, enters into, in this case, the left mainstem bronchus, goes through all these little tiny tree-like structures called the bronchioles. At the end of the bronchioles, then, it terminates into the alveoli. The alveoli then are wrapped in these capillaries. Capillaries allow for the exchange of gases to occur, and that is how the respiratory function or respiratory system contributes to the functions of perfusion. So in order for all that to work, the airway itself has to be patent. It has to be open, unobstructed. We have to be able to move air from outside the body in down to those alveoli. Any type of airway obstructions are going to prevent that. So as you may have heard in the past, without an airway, you don't have a patient, and that's the truth. We need to ensure that we have that open airway to allow for the exchange of air in and out of the lungs. The lungs themselves are part of the lower airway. What divides upper from lower airway is the larynx, or where the vocal cords are at. Anything that is above that is considered upper airway. Anything that is below that is considered the lower airway. Now, every time I take a breath in, the amount of air that exchanges, that goes inside my body, and then as I exhale, the amount of air that pushes out, that is called my tidal volume. So the amount of air that is exchanged with every breath. Now, if I take my tidal volume and I multiply that by my respiratory rate, and if you remember when we talked about the anatomy chapter, we said that respiratory rate is kind of misleading because as we watch chest rise and we watch a patient breathe, we're actually assessing their ventilation rate. So tidal volume, the amount of air for each breath, multiplied by the number of ventilations that they make in a minute, right? So the number of times that their chest rises, together that total number equals the minute volume, or the volume of air that's exchanged over the course of an entire minute. Now, we can fluctuate our respiratory rate a little bit, here and there, and it doesn't make a big difference. But at the end of the day, based on the activity level, based on the oxygen demand of the body, we have a functional amount of air that we must exchange routinely in order to ensure that we're bringing in enough oxygen to meet the demands of the body. So when that doesn't happen, that can become an issue that prevents the overall quality of perfusion. So here it says any change in tidal volume or respiratory rate reduces minute volume. Now this is better represented. I've got a little thing that I'll bring up here for you, and it kind of shows the relationship between respiratory rate, tidal volume, and minute volume itself. All right, so looking here, we have respiratory rate, the number of ventilations per minute, multiplied by the tidal volume, the volume of air in each breath. Together, that gives us minute volume. Now, under normal circumstances, an adult patient breathes between 12 to 20 times per minute. So we'll use the number 14 here. Based on their current activity level, based on their current oxygen demand, what they need is roughly 7,000 milliliters of air exchange every minute. So if their average adult is 500 milliliters of air for every breath, they're breathing 14 times per minute. That gets them that 7,000 milliliters per minute of air exchange back and forth that meets the oxygen demands of the body. So this would be considered a normal respiratory effort. Now what happens when we go into, let's actually jump to the bottom here, into respiratory distress. Here, our body is going to compensate because it wants to maintain the same minute volume. And as long as our body can compensate for any deficiencies and we can still meet the demands of the body, we can continue to live. However, as this goes on, our body will eventually get fatigued and it'll stop functioning correctly. So in this case here, the body knows that 7,000 milliliters of air per minute is the amount of air that it needs to exchange in order to meet its demands. So we want to get to 7,000 milliliters here. The problem is, let's say that this is an asthma patient and their lungs constricted down, and because they constricted down, now they're only moving 292 milliliters of air per minute as opposed to 500 under a normal circumstance. In order to reach 7,000 milliliters, we would have to increase our respiratory rate to 24. So 24 breaths per minute multiplied by this reduced tidal volume of 292 milliliters gets us to 7,000 milliliters overall. Now again, as my respiratory rate increases, right, over time my body's going to get tired. Not to mention the fact that in order to increase my respiratory rate, I also have to increase my heart rate, which also increases my oxygen demand. So now this 7,000 technically won't be good enough. So this minute volume number will continue to rise as the oxygen demand rises, and the body just over time will not be able to continue to compensate and keep up. So what happens when it's tired, it's fatigued, it can't keep up anymore? The respiratory rate drops. The muscles in our chest give up. They're exhausted at this point, and we go into what's called respiratory failure. Now, respiratory failure is indicated by a substantial drop in respiratory rate. We're just too tired. We just can't breathe fast enough anymore. So as our muscles kind of poop out, you'll see a substantial drop in rate. So now this patient is breathing 6 times per minute. And in this case here, assuming that they're still even exchanging a normal volume, you'll see here that their total minute volume is down to 3,000. So looking at this, let's say that this is a heroin overdose or a narcotic overdose in general. What heroin does is it causes respiratory depression. It'll put a patient into respiratory failure. So although there's no asthma, their lungs are working just fine, it doesn't impact our tidal volume, we're still able to move 500 milliliters of air per minute like we normally would. Since the heroin dropped our respiratory rate down to 6, now our minute volume is only 3,000. So you'll see that this is less than half of what the body normally needs. Therefore, the body is not perfusing adequately, and the body itself is going into a state of hypoperfusion or even a shocky state. So again, once the rate drops down, that's respiratory failure. When the rate increases, that's respiratory distress, and it's trying to compensate to maintain the same volume overall. So I know that this may be a little confusing. We'll talk about this a lot more in class, but we need to understand, why is it that the respiratory rates are changing? What happens when it goes up? What happens when it goes down? And then beyond that, this is just a single component. We also need to begin to think about what happens with the heart, because this is the cardiopulmonary system, right? That's what we're talking about. So when the respiratory system makes changes, how does the cardiac system also change to reflect that? All right, so looking at disruption of respiratory control, we just talked about drugs or toxins as being one potential cause. There's also the risk of things like stroke or other neurologic issues that could come into play. Really, there's countless issues, countless causes of respiratory dysfunction. And that's going to be our job as EMTs to assess, to identify, and treat those underlying causes. Something that you will see again is the medulla oblongata. So the medulla oblongata sits on the brainstem, and that is our respiratory control center. So anytime that there is an issue with perfusion or a disruption in the messages that are sent from the medulla oblongata to the body itself, we're going to have that respiratory compromise. All right, so disruption and pressure. The chest itself, so we talked about in the anatomy chapter the concept of active versus passive respirations, right? Or ventilations, rather. As I breathe in, I utilize muscle to expand my chest. As the chest cavity increases, the pressure inside becomes lower than the outside air pressure. Therefore, air rushes in order to balance it out. As I exhale, all of my muscles kind of relax. The chest cavity compresses down. It compresses all the air inside my chest, causing the air pressure inside there to be higher than the air outside the body. Therefore, air rushes back out in order to balance things. That's all assuming that my lungs are intact, that I don't have any holes in them, that I don't have any holes in the outer wall of the chest, that prevents the lung from expanding correctly. There's a few physical things that can prevent the pressure from being equalized there. And in those circumstances, we need to identify and fix those. And we'll talk a lot more about that stuff when we get to the trauma chapters. Lung tissue itself, when patients have emphysema, for instance, that actually causes the lung tissue to lose elasticity, so it can't stretch and manipulate itself as much as it should. In that case, we start to lose a lot of tidal volume. There's a bunch of other things. If you think about just a general smoker's lung, that type of stuff, as time goes on, if the lung itself loses overall functionality, then that affects our tidal volume and our overall minute volume, and therefore affects our perfusion abilities. So respiratory compensation. We talked about that through those formulas where the body tries to compensate for things. There's far more to it than that simple little formula sheet that I showed you. But that's just kind of an introduction. Start thinking about how when one thing changes, when one part of the body starts to compensate, how does that affect other parts of the body as well? And you'll see here chemoreceptors. Chemoreceptors detect a changing level of oxygen and carbon dioxide in the blood. So what happens is these chemoreceptors, they actually sense carbon dioxide. And leading up to this, you may have always thought that oxygen levels kind of dictate how our body responds. And that's not the truth at all. Because oxygen levels don't tell us anything about perfusion status or metabolism, the body actually looks at carbon dioxide. Carbon dioxide is the end product of metabolism. So as long as the oxygen is coming into the body, getting delivered to the cells, being utilized from metabolism, carbon dioxide should be produced. So the body looks at the overall carbon dioxide levels as the end product of efficient metabolism. Are we metabolizing correctly? So when the body senses that the carbon dioxide levels are too high, then it says, okay, that's fine. For whatever reason, we're producing too much. We need to increase the respiratory rate. Because as we increase the respiratory rate, we can then breathe off some of those carbon dioxide levels, bring in a little bit more oxygen, and balance things out. What ends up happening is if we don't get rid of carbon dioxide, we become acidic inside of our body. Carbon dioxide is a form of acid. And the body does not tolerate any imbalance in pH whatsoever. The body wants to always remain at that neutral state, that state of homeostasis. So as the carbon dioxide levels increase, we become more acidic. The body doesn't like that. It increases the respiratory rate in order to kind of get rid of some of that CO2 and balance things out. Conversely, if there's not enough carbon dioxide in the system, it'll actually slow down the respiratory rate. And as it begins to slow down that respiratory rate, it's in an attempt to build up that carbon dioxide. Because again, we need to have that even balance of alkalotic and acidic components in our system in order to remain neutral for our pH. So there's 4 parts of blood. We talked about that in anatomy also. The plasma, the red blood cells, the white blood cells, and the platelets. Most important for the perfusion component is going to be the plasma, which represents our overall hydration levels, and the red blood cells, which allows us to actually bind the oxygen and deliver it down to the cells. And as you can recall there, the hemoglobin is part of the red blood cell, and that's what the oxygen itself actually binds to. Now, when we're talking about hydration levels and statuses, we said at the beginning of this chapter that the cell must remain appropriately hydrated. It needs to have enough water in it. And as we begin to balance those things out, the body has all sorts of ways to kind of pull more in or get rid of too much. And the plasma oncotic pressure here it's a system of proteins that are around the cells, and it pulls the water from the bloodstream itself into the interstitial areas and then allows the cells themselves to absorb that water to remain hydrated. In cases where we have too much water in the tissues or too much water in the cells, then the hydrostatic pressure actually pushes the water back out, and it'll push us into, or push that water back into the blood vessels, and it'll allow us to excrete the excess through our kidneys as necessary. So once we have any issues with these proteins, it can really, again, affect our hydration levels and affect the overall function of the cell. So here we got blood dysfunction. Without enough blood, oxygen and carbon dioxide cannot be properly moved around. So the blood itself, think about all the blood circulating throughout your body. If you didn't have any blood, we can't deliver oxygen. We also can't get rid of the carbon dioxide. And that goes back to the example I used of putting a tourniquet on my arm. If we don't have blood flow or blood supply, nothing's going to work appropriately. And beyond something as obvious as bleeding or hemorrhaging, something simple like anemia or liver failure could also play into that, and that's something that we'll talk about on a later time or at a later date. So another quick reminder here that oxygenated blood travels through the body through the arteries. It goes then down into small arterioles, which are mini arteries. Those branch into little tiny microscopic capillaries. Capillaries are where the gas exchanges occur. From there, then, it would get rid of the oxygen. The oxygen would get pushed out into the cells. The cells would push carbon dioxide back into the capillaries. Capillaries take that carbon dioxide and it returns it back through the venules, eventually into the larger veins, back to the lungs, and excretes it out through the respiratory process. So kind of a recap of what I just mentioned there. Again, I'm going to say this, I think, for the third or fourth time this discussion. Capillaries, that's where the gas exchange occurs. Capillaries is where the gas exchange occurs. And that's the exchange of both oxygen and carbon dioxide. They kind of flip-flop there. Why have I said it so many times? Well, just maybe that's an important concept to remember. All right, so blood pressure. We need to ensure that we have an adequate pressure to make everything work together. There has to be enough pressure inside the blood vessels to actually push the oxygen out of the vessel itself and get it into the areas where the cells can begin to utilize it. If our pressure is too low, none of that will work. So even if I'm breathing normally, even if I have enough blood in my system, if I don't have the right pressure, then again, perfusion won't play out the way it's supposed to. So now we're talking about, I need to make sure that I'm bringing in enough oxygen. I need to make sure I've got enough blood. I need to make sure that I'm properly hydrated. I need to make sure that I have enough red blood cells. And now I also need to make sure that my blood vessels themselves are the proper diameter to adjust, to make sure that the pressure is correct. There are so many components to perfusion, and all of them are things that we need to be able to assess externally. We need to look for signs and symptoms unique to any one of those specific functions and try to identify what's going on, what's being interfered with, and how is it that I can fix it. So what ends up happening is we have stretch receptors that monitor the overall pressure, and we need to maintain a relatively constant pressure in order to efficiently push oxygen out and perfuse all tissues of the body. Now, as you can imagine, we have to have higher pressures to get to further distances of the body. So in order for me to perfuse the very tip of my toes, I need to have a substantial blood pressure to actually push the oxygen all the way down there and have enough residual pressure to push the oxygen out into the tissue. So these stretch receptors monitor the overall pressures, and it can kind of tweak things as necessary. If my blood pressure is too low, the first thing my body is going to do is it's going to constrict down those blood vessels. And as those blood vessels constrict, it increases the pressure on the volume inside of it, or the blood itself. Conversely, if my blood pressure is too high, or in the cases of something like an allergic reaction, if I have something inside my bloodstream that I don't want to get out of it, if I don't want this allergen to get out of the bloodstream and into the cells, then my body will purposely dilate the blood vessels. And by dilating the blood vessels, it substantially drops the blood pressure, and then it doesn't give us the ability to efficiently perfuse the oxygen out into the cells. So the blood vessels themselves have these stretch receptors that kind of help us monitor a normal diameter of the blood vessel to achieve an appropriate blood pressure itself. In addition to the constriction, the blood vessels can become very permeable. They can start to leak. They can also lose overall tone, which is just a reduction in their ability to constrict or dilate. So we have potential neurologic issues that can interfere with that. Trauma, infection, allergic reaction, as you can see at the bottom there. So these are all issues that play into it. Now this is a great picture because it shows, here a normal blood vessel should be completely full of blood and should have a relatively constant pressure being pushed out against all sides of the blood vessel. Okay, and as long as this pressure is high enough, the oxygen can push out through the capillaries, get into the areas that can be utilized by the cells. Over here in this one, though, you'll see that we don't have a lot of volume. So maybe this patient has a traumatic injury and they're bleeding out, right? So the amount of blood inside our system is no longer sufficient. Or in this case, if the blood vessel is self-dilated, as the blood vessels, and it's not just one, right? All of our vessels do this. As our entire body dilates the blood vessels, now the amount of blood that I had in there is no longer sufficient to keep it full. So it's only partially full in this case. My blood pressure is going to be substantially lower because, as you can see, I'm not excreting any pressure against the walls in some areas. So my blood pressure substantially drops. I can't push the oxygen out through the capillaries, and it's a real bad day for everybody. The excessive permeability a lot of times is a result of infection. Sepsis is a big thing these days. It was something that we always talked about in the past, but over the last couple of years, the awareness level of sepsis patients has really kind of taken off. We've learned that many patients are septic that we didn't even realize that they were in the first place, and just how important fighting sepsis or widespread infection is what sepsis is. How important it is to the overall ability to maintain a good quality of life and treat our patients. So kind of a little bit of a picture there of what permeable capillaries may look like. In this case, instead of being able to keep all the fluid, all the plasma and stuff inside the vessel where it belongs, the blood vessels kind of become permeable and stuff leaks out. And in this situation, we're actually going to go into a state of shock. Sepsis is a form of shock. And the reason is because all the fluid that we need here has now leaked out of the vessels. It's just sitting in the tissues. Our tissues start to swell up and get flooded. And as a result of that, we're no longer able to move oxygen through the bloodstream and get it down to the cells. All right, now we're going to start talking a little bit about components of blood pressure. Before we get much into hypertension specifically, let's look at this second bullet point, systemic vascular resistance. The systemic vascular resistance is the amount of pressure that the left ventricle must overcome in order to pump blood out of it. So there's a constant amount of pressure in all of the blood vessels in our body simply because there's blood in there. When the left ventricle contracts, it has to overcome that pressure in order to push new blood into the system and to circulate the remaining blood around and eventually get it back to the heart. So when we talk about hypertension, hypertension is a term for high blood pressure. And what ends up happening is the systemic vascular resistance throughout the rest of the body is too high. And as a result, the left ventricle must work harder and harder and harder in order for it to overcome that systemic vascular resistance and to actually push blood out into the rest of the vascular system. The downside of hypertension, right, if we simply have high blood pressure for a short period of time, a couple hours, a few days, that's typically something that we can kind of deal with, and it's not going to be a big life threat. Where the issue lies is people who have hypertension and either A, don't know it, or B, choose not to address it. And it can be treated through medication, through diet, through exercise, through a handful of different methods. But when people choose not to address or treat their hypertension, the heart, like every other muscle in the body, continuously has to work harder and harder and harder. Well, if I continue to work out my bicep day after day after day, what happens to my bicep? It gets larger. The same thing happens with the heart. If the heart is overworked because of this chronic high blood pressure, then it gets larger. But the problem with the heart is that it doesn't get larger on the outside, it gets larger on the inside. So the thickness of the walls of the heart actually close in on those chambers inside the heart. The chambers get smaller as the walls get thicker. And as those chambers get smaller, it affects the overall cardiac output, or the amount of blood volume that the heart is able to push out, and it can really impact our ability to adequately perfuse. So the heart, we talked a little bit about tidal volume and respiratory rate with the lungs. The same thing kind of applies to the heart. The heart itself pumps an average stroke volume of about 70 milliliters of blood per contraction. Now, thinking about that really quick, 70 milliliters of blood per contraction, and let's say that the average heart rate is 80. 80 times 70 is 5,600. 5,600 milliliters. That's 5.6 liters of blood that circulates throughout your heart every single minute. The average adult has 5 to 6 liters of blood in its body. So what that says is that every single minute your heart circulates just about your entire blood volume. That's incredible. So think about how important that is. And if the heart stops functioning appropriately, if the stroke volume is decreased because of that hypertrophy from the long-term hypertension, where the heart muscle closes in on those ventricles, if we're not pumping enough blood with each contraction of the heart, that's going to really reduce our cardiac output, and then we're no longer going to be able to meet the perfusion demands of the body. So everything that we talked about with the lungs increasing in rate, trying to compensate, and what happens when the lung gets tired and the rate drops, all of those same principles apply to the heart itself. So stroke volume, the amount or volume of blood that is pushed out of the heart with every single contraction. There's a few things that impact overall stroke volume. Preload. So preload is the amount of blood that is coming back to the heart from the rest of the body. If there's not enough blood coming back to the heart, you can only get out what you put into it, right? So I need to make sure that I have a sufficient preload so that as the right atria opens up and allows blood in, it's being primed efficiently and it's able to circulate the appropriate volume of blood from there. Contractility plays into it. So that's how hard the heart squeezes. When the heart contracts, it's not this gentle little squeeze or gentle little contraction. It's this hard, forceful contraction. And it needs to be that in order to forcefully overcome the systemic vascular resistance to push blood out into the rest of the system. Speaking of systemic vascular resistance, afterload. So systemic vascular resistance is afterload. If for whatever reason the SVR or the afterload is so substantially high that the heart is just not able to contract forcefully enough to overcome it, then we're going to really reduce or potentially eliminate the amount of blood that can be pumped out at any given time. So any one of these three things here can really affect our stroke volume. There's also some other things that can affect it, such as heart rate and stuff like that. So here, looking at stroke volume, the amount of blood that the heart pushes out with every contraction, multiplied by the beats per minute, that gives us our total cardiac output. So for the lungs, it was our overall minute volume. For the heart, it's our overall cardiac output. The rate obviously plays into it substantially. If my heart rate slows down, that's going to be a big deal because my heart's not able to circulate enough blood. It's going to decrease cardiac output. Conversely, if the heart rate speeds up too fast, there's times that the heart contracts so quickly that there just isn't enough time to refill it with blood between each contraction. And in that case, obviously, it's going to decrease our cardiac output also. We can also deal with mechanical problems, physical trauma. If there's some type of blunt force trauma to the heart, causes a pericardial tamponade, a few other items. What about cell death itself? That's a heart attack. In the event that we have a heart attack, obviously the heart doesn't function properly, and that's going to decrease our cardiac output. Electrical problems. If we are dehydrated and our electrolytes are imbalanced, it can throw us into a cardiac dysrhythmia, causing electrical issues. So there are so many different potential causes of cardiac output interruption. Again, we have to be able to treat or assess and treat our patients for whatever these causes may be. And it's not easy. There's such an incredible amount of information that you have to know in order to be able to properly identify this stuff. We're going to go over all that throughout class, but it's really important that you guys begin to realize as of this very second just how in-depth and how detailed we're going to get. This is going to require a substantial amount of time, studying, and patience on everybody's behalf in order to make sure that you guys can retain this information, that you can understand it, and most importantly, that you can apply it. Okay, we need to develop a level of proficiency in dealing with our patients. So I told you earlier that the cardiac system and the pulmonary system, they work together and they have to kind of keep up with each other. What one does, the other does. And that's the same thing when we start putting it all together here. So the VQ match, ventilation and perfusion systems together, where V represents ventilation and Q represents the overall perfusion. There has to be a match there. If our ventilatory rate increases, it's typically as a result of a demand for perfusion. And along with that, as the respiratory rate increases, so does our heart rate. And those things should work together in tandem in order to maintain the appropriate perfusion status for the body. All right, we're getting into shock. So shock is going to be one of the biggest life threats that we have to deal with our patients. There are many different forms of shock. There's categories of shock, types of shock, all sorts of stuff about shock. You must know everything there is to know about shock. So pay special attention. Listen to this part 2 or 3 times. Read through the book 10 times. Utilize the resources in my Brady lab. Ask questions in class. You must absolutely understand shock. You will be tested on this on every single exam from here on out. You will be tested on it on your national registry exam. You will be expected to know this inside and out. So I hope I made that clear enough for you. So we need to maintain adequate perfusion levels. If we're not perfusing sufficiently, that's called hypoperfusion. Hypoperfusion is shock. So I just spent the last 40 some odd minutes talking about the concepts of perfusion and how it works and what's required in order to perfuse. When any of that breaks down, when any of that isn't working efficiently, it's hypoperfusion. That is our shock. Okay, so shock itself is hypoperfusion. There are 4 categories of shock: hypovolemic, distributive, cardiogenic, and obstructive. You have to know all 4 of those. Okay, and if you look at them, you can almost kind of guess as to what they are. So hypo and volemic, volemic meaning volume, hypovolume, not enough volume, so we don't have enough circulating blood or something like that is going on. So there's an issue with the quantity of blood in our system if we're hypovolemic. Distributive talks about the distribution system. So that has to do with the blood vessels themselves and the overall ability for them to remain to maintain adequate tone, adequate pressures, and stuff like that. Cardiogenic has to do with the heart, the actual pump, and then obstructive is typically an outside force. So something may be related to trauma or something else that interferes with the overall ability for everything to work together in unison. Any one of those four categories of shock could play into it. Now, we can also, when dealing with some issues, have multiple categories that are in play there, and we'll learn more about those throughout the semester. So I talked earlier about how the body tries to protect itself. The body compensates for things. And when it recognizes that there's hypoperfusion occurring, it begins to compensate. And it may do that by increasing respiratory rate, and therefore it increases the heart rate. It may do so by constricting blood vessels. There's just so many different things that it can do. So we need to be able to recognize when the body is compensating. If we wait until after the compensation is done, it's too late. Our patient has gone into that decompensated stage of shock, and that's going to be something where there's going to be damage that's done that's most likely irreversible, and we could be knocking on death's doorstep at that point also. So what are some of the signs of compensated shock? Changes in mental status. Anxiety or confusion would be indications there. An increased heart rate, increased respiratory rate. These are all early signs of compensation. Delayed capillary refill. So if I were to squeeze the fingertips or the palm of the hand of my patient and it takes more than 2 seconds for the color to return there, that would be an indication of shock. Pale, cool, clammy skin, sweating, and in class we'll really get into the details of why all these things occur and what it is that we should be looking for. But we need to be on top of recognizing these potential signs and taking action to prevent it from getting any worse, and in a perfect world, make it better. So the transport of carbon dioxide here, we'll play this one also. This actually is a pretty productive video.
What happens to the carbon dioxide that leaves the tissues? Most of it diffuses into the bloodstream, specifically into red blood cells. There, much of the carbon dioxide is rapidly converted to carbonic acid by the enzyme carbonic anhydrase. The carbonic acid then dissociates, releasing a bicarbonate ion and a hydrogen ion, that is, a proton. As a result, the blood pH drops. Changes in pH affect the shape of hemoglobin and thus its ability to bind oxygen. For a given partial PO2 value, hemoglobin can bind less oxygen at lower blood pH and more oxygen at higher blood pH. This effect is known as the Bohr shift. The drop in blood pH leads to the unloading of oxygen by hemoglobin. The protons released by the dissociation of carbonic acid bind to deoxygenated hemoglobin. Hemoglobin thereby acts as a buffer, preventing large swings in blood pH. In the form of bicarbonate ions, carbon dioxide can thus be transported by the bloodstream from the tissues to the lungs with a minimal effect on blood pH. When deoxygenated blood reaches the alveoli, the environment changes dramatically. In the lungs, a concentration gradient favors the diffusion of CO2 from the plasma and red blood cells to the atmosphere. The partial PCO2 of the blood drops, promoting a reversal of the reaction that occurred in the tissues. Bicarbonate is converted back to CO2, which then diffuses into the alveoli and is exhaled by the lungs. With the next inhalation, oxygen is picked up, and the cycle continues.
All right, so there's a lot to take in there. But here's the big thing to understand. We know that the production of carbon dioxide is good. That's a product of metabolism. We want that to occur. And we also know, based on that video, that having too much carbon dioxide, it affects the pH balance of that blood cell. And as that occurs, the hemoglobin helps to kind of buffer that out. So when our carbon dioxide levels are high, then our hemoglobin is less effective at taking on oxygen. Now, so long as we're able to get rid of that carbon dioxide and excrete it through the respiratory process, it's not a big deal. That's part of normal everyday function. But what happens now when we can't get rid of that carbon dioxide for whatever reason. What happens when our asthma patient or our COPD patient is trapping air in their alveoli, it's stagnant, and now the carbon dioxide levels are too high? Well, what ends up happening is that the hemoglobin remain incapable of attaching to the oxygen because it's trying to deal with that excess carbon dioxide. So having too much carbon dioxide is bad, and the way we would balance that out is by excreting it and bringing in oxygen. But when the levels get too high and we're not able to excrete it, we're also not able to bind the oxygen, and that affects the overall ability for us to deliver oxygen to the rest of the tissues. So it's an instance of where one problem compounds on top of another problem if we can't identify and fix it. So I hope everybody begins to understand now that although you may not be able to recite everything that just happened there, and maybe you can't get down to the pathophysiology at the cellular level, there's a lot that's going on, and our treatment and our ability to identify problems is going to directly impact that. And there's a reason that we have pre-hospital EMS, and that's so that we can get out there and rapidly identify these life-threatening issues and provide early interventions long before they ever get to the hospital. And every single second that we're able to provide an intervention, that's one more cell that's saved. Okay, so that's a lot, and I know that your brains are probably starting to feel pretty fried right now. We're going to reinforce this a lot in class. As a matter of fact, we're going to reinforce this every single day from here on out throughout the rest of the class. And then when you go to paramedic school, you're going to reinforce this every single day there. And then when you're working in an EMS system, your CEs, your continuing educations, that's going to reinforce this on a regular basis. So it's something that should always remain fresh in your head, okay? We're not quite done yet. We're going to quickly go through the pathophysiology of some of the other major systems of the body and how they impact perfusion. So if you think back to the lymphatic system helps to kind of balance out all the water in your body. And one of the things that we have to consider with water is that our body is about 60% water. So that's a substantial amount, as you can imagine. But here's what's funny. When we think about all the water in our body, we think about it being in our blood, right? Component of the plasma in our blood. In truth, though, only 5% of the water in our body is inside the vessels themselves. It's intravascular. 70% of the water in our body is actually inside the different cells. 70%. So that's where the dehydration becomes such a problem, because as we dehydrate, it's our cells that really take the big hit. The remaining 25% here is in the interstitial space. And interstitial space is the space kind of in between cells. So it's outside of the blood vessels, but it's not inside the cells. It's just surrounding the cells themselves. So really important, again, that we maintain the proper hydration levels and that we're monitoring that with our patients. The fluid balance will be impacted by our brain and kidneys. So people with kidney failure are unable to excrete a lot of that excess water. They start to retain fluids. And as they're retaining a lot of the fluid, they're also retaining the waste products that they're normally supposed to excrete through their urine. So we've talked quite a bit about fluid loss. I think everybody should hopefully have that dialed in by now. The nervous system, brain and spinal cord, we know that those are well protected. Coincidentally, they're surrounded by cerebral spinal fluid, which is made up partially of water. But in the event that the nervous system is damaged, that impacts the ability for the brain to communicate with blood vessels in order to constrict or dilate as necessary, and that can impact our overall perfusion status. And obviously there's a substantial number of causes that can impact our nervous system. Some of the medical issues: strokes and infection, low blood sugar being hypoglycemia, also toxins and drug use. Talking about the endocrine system then, on the topic of diabetes, the endocrine system produces the insulin that is required in order to bring the glucose into the cells. So if there's no insulin, then the glucose can't get into the cell and metabolism can't occur. The body will die. In some circumstances, patients produce insulin, but they don't use it efficiently. So that's usually our type 2 diabetics. And in those situations, we have to, or the patient themselves, take a certain prescription medication that helps to kind of bring those sugars into the cells. In addition to that, though, the pancreas also produces something called glucagon. So glucagon takes all of the sugar stores that we have in our liver called glycogen, and it converts the glycogen back into glucose and allows us to utilize some of those stores. So under normal circumstances, if an individual who is not a diabetic, their sugar levels drop simply because, let's say that you ran a marathon and you didn't eat before or after, okay? Pretty stupid of you, but let's say that happened. Obviously, the amount of sugar that you're using to metabolize during the course of that marathon, if you didn't eat leading up to the race, you're not going to have enough fuel to get through there. So what happens is the pancreas produces the glucagon, and the glucagon takes the glycogen stores in the liver, converts those back to glucose. I know, a whole lot of G words. And then we have those excess stores available to be used for energy production. So a bunch of stuff going on with the endocrine system. As you can see here, the brain, even though it's a component of the nervous system, also ties into the endocrine system. The kidneys, I mean, it just goes to show that all of the systems are intertwined. They don't have a certain function and that operate independently of each other. They all rely on each other in order to function. And that's why we need to know both primary and secondary functions of every major system of the body. So a little bit about the dysfunction of the endocrine system, and I kind of just hit on that with the diabetic component there. There's a few other things, but we'll get into more depth when we actually talk about the endocrine system. Digestive dysfunction, you may not think about your digestive system as playing much of a role when it comes to perfusion, but in fact it does. The amount of fluid that you retain is directly impacted by your large intestine. I'm sure we've all experienced a little bit of diarrhea in our life, and in that circumstance, what's happening is the large intestine is either pushing out too much water or it's not absorbing enough water. But the large intestine, as I go to drink water right now, the water enters in, goes down my esophagus, into my stomach, goes through the small intestines, and it's not until it really gets to the large intestine or the colon that it starts to suck a lot of that water into the body and utilize it for different purposes. So if there's something wrong with that large intestine, whether it be a cancer, bleeding, or other issues, then that could impact the overall volume of water in our body and impact our perfusion status that way. Let's see here. Same thing is along the lines of digestive system. Rather than diarrhea, if I vomit, if I can't keep things down, I can become dehydrated. I'm sure most of us have experienced that if we've been ill with the flu at some point in time. The immune system, I talked a little bit about allergic reactions turning into anaphylaxis and it being an exaggerated response of the body. That's where the immune system is trying to fight what it perceives to be a threat that got inside of the body. And because of that exaggerated response, the protection mechanisms actually end up harming the body more so than anything else. And that same thing, that's along the lines of the hypersensitivity or allergic reactions. We'll get into all that stuff in more detail. As a matter of fact, allergic reactions are a chapter in and of itself. So that's an hour and 4 minutes of perfusion discussion. Your brains are probably scrambled right now, and I guarantee you we'll continue to work on this. We'll hit on this more, but understanding the concepts of perfusion, how the body will display inadequate perfusion, what are some of the signs and symptoms you should be looking for. Those are the most important things that I need from you from here on out, okay? Everything will be focused or revolving around the concept of perfusion. So I hope you learned a little something from this. If you have any questions, as always, reach out to any one of your instructors. Have a great evening.